people will come in, they'll be like, well, my friend's having hot flashes and I just can't sleep at night. I don't, she's perimenopausal, but I'm not because I'm not having hot flashes. And I'm like, listen, we all have our own backpacks with the perimenopausal symptoms we're carrying around, that are impacting our life. So you're not going to have the same exact thing as your sister, your mother, your, daughter, your best friend, and whatnot.
Welcome to recoverHER, the podcast where your healing journey begins. I'm Heather Novak, and I'm here with my co-host, Dr. Tracy Oppenheim, a compassionate psychiatrist. Today, we embark on a path of recovery and self-discovery. We are dedicated to inspiring each and every one of you to overcome your struggles and live your best, most fulfilling life. Your recovery starts now, and we're here with you every step of the way.
It's only up from here, 'cause there's no one else that's me.
Welcome back to recoverHER. Today, I'm thrilled to sit down with Dr. Leigh Lewis, a certified menopause specialist with over 25 years of experience bridging hormone health and mental well-being through an integrative lens. Trained in neuropathic medicine and reproductive mental health, Dr. Lewis earned her certification from the Menopause Society in 2011 and has served women and transgender men through perimenopause and beyond. At Arcadia Women's Wellness, she offers telehealth appointments that center on personalized evidence-based care, from hormone therapy to lifestyle counseling and metabolic health. Dr. Lewis's philosophy is rooted in empowerment. She believes health is a journey of progress, not perfection. Her approach is deeply compassionate, blending medical treatment with education to help midlife women reclaim their vitality. I can't wait to explore her insights on healing, hormonal balance, and the unseen strengths at midlife. Welcome. So important. Gosh, you're one of the reasons why we're doing what we're doing at recoverHER, to be honest. And I think that we're just all, so many of us and our listeners are stepping into the second half of their lives, whether their kids are off in college or, the late 30s, their 40s, and into their 50s and beyond, that second half of their life with so much vitality and just excitement about stepping in to the new realm of the possibilities of who we can become.
For sure. One of the reasons why I really enjoy this time of life and working with women just like ourselves is, I do feel, I know a lot of people have a lot of different ideas of what the perimenopausal or menopause transition means for them and how it relates to where they are in their life. But I do like, people, if they're in a position to do so, to take a step back and really be able to assess where they are in their health and their mental health. And, are they doing things that really fulfill them? Do they find activities that are fun for them and keep them healthy? Are they eating the way that is best and helps them really nourish themselves and not just, grabbing the closest thing? A lot of women, by the time they hit, 40s and 50s, a lot of time has been spent caring for other people, or they find themselves caring for even more people as maybe their parents get ill or their family members get ill. And so I just think it's a great time to reassess, what's going on in all aspects of life and health.
Yeah, absolutely.
Yeah, very, very, very well said. So I'm being a little cheeky, but we like to start off with a game of Would You Rather. So for you, we were thinking it could be fun to ask, would you rather have the worst hot flash at a pivotal moment in your life, a once-in-a-lifetime experience, maybe where you don't get a redo, or would you rather have the brain fog that can come with menopause for a month?
Oh, a month. I would probably take the hot flash because that has an end point at some time. So that would be my would you rather. Yes.
Yeah.
All right.
I agree with you. I would have taken the hot flash. I found Dr. Leigh Lewis through a few different mutual friends of mine. Julie Adelson sent me to you, and I was in the midst of those horrible hot flashes. You used to take pictures of me. When it would happen, I would just kind of brace myself and just wait. And I would beat up, and then of course it would pass. But people used to just make so much fun of me, including you, and would take
Absolutely.
pictures like, "Oh, you're beating up," like a photograph of that. I'm like, come on. But I did show up. I think one time you had me tracking how many hot flashes I was having, and I was in my late 40s, and I had 30 hot flashes within a 24-hour period of time. And it was horrific. You can't sleep. You're laying in bed absolutely soaking. You're having hot flashes as you move through your day. And, and after some work and blood work, and then going through some of my individual panels with you and getting on HRT, which has been so, so helpful. I think Tracy was the one that said, and has a story of her own, that once some of the HRT enters your system, you'll have 3-4 days and you'll feel like yourself again. And, 6 months later, I came back into your office and you said, how are things going? And I said, good. I've minimized my number of hot flashes. I think I have about 6 now a day. And you said, oh, that's not good enough. We're going to get you down
That's too many.
yeah, it's way too many. You're going to live your best life. You're walking into your second half. I want you to feel great. And, so thank God there's doctors out there like you that are advocates for all of us, because I've been approached by so many other women. I don't want to throw the male physicians under the bus, but I don't think that there's no way they can understand. And, some of them have just been lost in that shuffle of simply just not believing some of the symptoms that you may have. And I know we'll go over some of that in our discussion, but the symptoms are crazy. And if you don't have the right medical help, you feel almost like you're going crazy.
Definitely. And we see this a lot in women's health at all time points along their reproductive lifespan, specifically, say, with endometriosis. We know that most women with endometriosis, I would put polycystic ovarian syndrome in that bucket, and also perimenopausal symptoms, that women will report seeing 6 to 8 physicians before they get any assistance that is really helpful to them. And there is just, like you said, it's kind of funny to have a hot flash. I think in our society that makes it easier to talk about. But for someone like yourself who is having 30 a day, a lot of people depend on where they work and what environment they're working in, especially if it's a very male heavy environment. That can be very embarrassing and make people not feel confident. Even if other people wouldn't necessarily notice, they think everyone is seeing what is happening to them. And it can really interfere with their employment and their work. And unfortunately, there's a good segment of the menopausal population that drops out of the workforce at this time because of some of those reasons. I mean, hot flashes is one, but you can imagine too, like the mental health symptoms that can come up and whatnot. And that can be very difficult to keep up a rigorous work schedule while you're having all these symptoms.
Teach our audience a little bit to kind of start from the beginning of when, I was hiking with a friend yesterday, and I'm very vocal about, so many women, it's still considered something that's really whispered about or almost taboo. And that was never my experience. I wanted to talk about it because I was experiencing it. I was asking everybody else if they were, or women who are a decade older than I am, had they gone through this and what they had done to eliminate some of the experiences that I was having, the symptoms. So tell us, so I was hiking with a friend yesterday, and when I was going through some of the heavier, more intense symptoms, she was a few years older than I was and just really had no understanding of what, she hadn't been there yet, or maybe skated through that process. And now today, she's postmenopausal almost and experiencing so many of those symptoms today, and now looking at getting on HRT in her early 50s. But at the time, she just didn't know. And so it was difficult for her to relate, like, oh, that sounds awful. That's not going to happen to me. So, why don't you start with describing what happens to us as women when we are simply done having children?
Right. Well, that is great. I think I'm going to even bring the lens back a little bit further in terms of like when can women expect to experience some perimenopausal symptoms. And quite honestly, it can really be, anywhere between after puberty to up until the final menstrual period. And then even beyond that. But let's just look at that time frame. And we know that there are some women, unfortunately, in the respect of wanting to have children or having healthy bones and healthy cardiovascular syndrome and whatnot. I would say that the youngest patient that I've worked with who went through menopause was at 24. And this was like, at that age, that's where we're looking at doing labs to confirm things because it would be so unusual for someone to have had regular menses and all of a sudden just stop. And that was this young gal. And we were able to confirm that, through the labs. And she was able to get the treatment she needed. But this can literally be at any time. Sure, most women will have their final menstrual period around age 51 to 52. Perimenopausal symptoms can start 10 to 15 years before that final menstrual period. So for most women, that's going to be the mid to late 30s. Mid to mid 30s to I would say mid 40s. Most women are going to start to experience those symptoms. Some women will start even earlier in their 30s because maybe their final menstrual period is going to be at 45. And I'll be talking a lot, I'm sure, about like throwing in labs. There are no labs that can tell you when you're going to go through menopause or how bad your symptoms are going to be or what type of treatment you should do or what doses of treatment you should do. It's just not used like that. So again, kind of focusing in on the women that are having like, the perimenopausal symptoms start in the normal time frame that we would expect. There's no lab testing needed for the hormones to, to confirm that. It's really, and again, I guess this gets back to what you were saying about a lot of women's experiences. You just need a provider that's going to sit there and listen to you and believe you. And I think there is something that unless you've experienced a hot flash, and I don't have to have cancer to be able to feel sorry for someone who has cancer. And if I was an oncologist, of course I'd be able to treat that person. But hot flashes, I think a lot of people minimize unless you're having 30 a day or you can't sleep and whatnot. So I think that there is something to that in terms of working with someone who has, at least the experience from the extra training. But oftentimes the very first symptom, and a lot of people don't experience this as a symptom of perimenopause, but it's the decrease in fertility. And we know that there is a decrease after age 30 and then another decrease after 35 and then certainly in the 40s. But that is really the first reflection a lot of us get that our, egg quality is decreasing, that our ovarian hormone production is decreasing. And it could be years more, but then you start to see when everyone's threshold is different in terms of when their symptoms would start. But then we start seeing things like the mood changes, vaginal dryness, increased urination, and hot flashes as we go down through or get older through the decades.
So name some of those common symptoms. You've mentioned a few, and then I've also read and had some experience myself of some really odd ones, including ear itching.
Yeah, so we'll talk about like the most common ones first, and that would be, of course, the hot flashes. Now, there's a lot of misunderstanding about the hot flashes. I've heard from patients that they have seen providers who said, oh, if you're not having hot flashes, these are not perimenopausal symptoms. And that's just untrue. Just like if you have a cold or say COVID, most people have had COVID by now. Some people lose their taste and smell. And some people get very, very sick and can't breathe. And other people have super high temperatures, but they don't necessarily have to have all the things for it to be COVID. And this is like the exact same thing. You don't have to have hot flashes to have them. And a hot flash does not have to be like what you described, where someone can see it or you're having 30 of them a day and it's really disruptive to your life. It could just be that you're the hottest person in the room, or that you're doing things that didn't used to cause you to sweat. And like this just happened to be the other day. I was like,
I'm always having a hot flash then.
Yeah. E- Even just things that are like, your normal household chores might start making you sweat, or maybe you're sweating during exercise that you never used to sweat during. So, all of those things are still hot flashes. The second most common, and I would say the most disruptive, more than, if I had to rate these things, more than the hot flashes, except for maybe those gals like yourself who are having so many of them, is the mental and emotional symptoms. 100%. I mean, there's very few people that I meet who are not having that as a predominant symptom, especially when you kind of roll into that insomnia or sleep dysfunction. It really is something that most people are struggling with. And again, maybe unlike the hot flashes, maybe it's not so funny to joke about it, over happy hour with your friends or something like that. It can be very serious, and we still have a huge stigma in this country about talking about mental health. And it, unfortunately, and that's where, especially with my practice, I really do try to break down that barrier. And health is health. Like if you're having anxiety or you're having depressed moods and crying for no reason, when you're watching appointments, that's just as important as having a hot flash, if not more so.
Echoing, as a psychiatrist, I think that's something that I see often, and it's very surprising that women who are at the right age, as maybe they've never had depression before, or maybe they have, but it's been stable for years. Same thing for with bipolar disorder and other things. How often that's overlooked in psychiatric care, versus it should just be standard, right? Just like we think of, okay, if someone has new onset depression, we want to check their thyroid, we order the labs for the TSH. Most times, I would say the average psychiatric practitioner does not take menopause or perimenopause into account. So I'm grateful that you're illuminating that.
Yeah, that is a big thing, because I've never had suicidal thoughts, but there were plenty of times prior to the right combination of hormone replacement treatments, that HRT, that I found myself sitting in my closet not wanting to be here anymore. And I'm like, what am I giving up? What's happening? Not having thoughts that are typical for me, for sure.
Yeah, and that's something, you said maybe some of the less common, even though under the umbrella of mental health symptoms, the easy crying and feeling worthless or hopeless and things like that, anxiety, panic attacks, palpitations, kind of all wrapped up, are very common. They also are very common, again, when we bring the lens back and look at the whole reproductive lifespan. Women, well, at that point, girls can have these problems going through puberty in relation to the hormone fluctuations that are so significant at that time. The same thing with the upheaval that happens before the menses every single month. And I've had women, who have such significant PMDD or, PMS that's really bad before the period, that with mental health symptoms, depression, anxiety, bipolar flares, whatnot, where they actually I've referred them to get their ovaries removed because they are so suicidal every single month that is like really the only thing. They've tried everything else and nothing has helped. And then, of course, another time of hormone flux where mental health symptoms are very prominent are perinatal and postpartum. We see that there. And then again in perimenopause. And we know that the women who've had difficulty earlier in their life around those times of hormone flux will have a higher risk of having that same mental health and emotional symptoms in perimenopause.
Yeah, and then the other stuff that's no fun. I mean, the brain fog is real.
Oh, yeah.
As well. There have been times in mid-sentence, I will literally just stop. The word's gone.
Yeah, the brain fog, and then forget, like you'll walk into a room and like, why did I come in here? Or, forget like something like I can't tell you, probably this month 3 times already, I like sat in the car and I didn't have my key.
Right.
The car's like, the key is not here. And I'm
Yeah,
like, okay.
yeah. You do
So where
spend
I
a fair amount of
swear I
time.
went by and picked it up.
Yeah, you do spend a fair amount of time backtracking. Why did I get here?
Okay, Dr. Lewis, you can solve a really important debate that Heather and I have had around this.
Okay.
So Heather assures me that prior to menopause,
Oh, yeah, this is a good one.
she did not struggle with excess flatulence. That she wasn't a gassy person. And if I'm being honest, I can attest to that.
Yeah.
I do think that that's
yeah,
accurate.
have not been gassy. Menopause, whoa, all bets are off.
How often do you see that?
A person struggles with flatulence.
Actually, yeah, any type of gastrointestinal upset can worsen during this time. So whether you've even been diagnosed with IBS or irritable bowel syndrome, which flatulence is a part of that picture, that can get worse for sure. And even I would say not 100%, but even sometimes the treatments can contribute that. We know that progesterone is a smooth muscle relaxer, which is great if you're having like pelvic pain, and it can actually decrease the tightness of the sphincter.
Sphincter tone.
Okay, that's
You're loose.
I'm loose.
Reflux birth, and then the worse, and then also the sphincter on the other end.
Right.
It can make flatulence, easier to escape. All that gas can easier to escape.
All right. Well, so loose sphincter, and I'm no longer suicidal. So win-win.
Oh, that's what I like to hear. That's what I like to hear.
That's
You
hysterical.
bring up a good point, because just getting to those random weird things, there's like burning tongue syndrome. I've probably seen like 5 people that have that. It's not a ton, but when people have it, it is their number one thing. The other thing that can happen is people have like weird, like paresthesias or kind of nerve sensations in their mouth where they feel like their teeth are itchy. Of course, this always happens when you're trying to go to bed, and then you're like, it's almost like a restless legs type feeling, but it's restlessness in your mouth. The itchy ears, itchy skin. A lot of that can come from too, that just not having estrogen is very drying, so if your ears are more dried out, the physiologic reaction is to make more earwax to like moisten it up a little bit. And so that's sometimes where we have like some of that discomfort in our ears. Same thing is happening in the vaginal area too, with vaginal dryness. And by putting estrogen in that area, we can soften everything up, improve tissue integrity, improve the pH of the microbiome down there, and really take care of a lot of problems. If you look at the list, like pretty much there's estrogen receptors in every system of our body. So you're going to potentially find symptoms in any of those symptoms or systems for that person. And I always joke with people, I'm like, because people will come in, they'll be like, well, my friend's having hot flashes and I just can't sleep at night. I don't, she's perimenopausal, but I'm not, because I'm not having hot flashes. And I'm like, listen, we all have our own backpacks with the perimenopausal symptoms we're carrying around, that are impacting our life. So you're not going to have the same exact thing as your sister, your mother, your, daughter, your best friend, and whatnot.
Yeah. I'm just a fan of making it more of a normal conversation so that we don't have these women don't have to suffer on our own as we continue to walk into the second half of our life, which hopefully will be the best half of our lives.
Yeah, exactly.
Are there myths out there that just drive you so nuts? And if so, can you share what some of those are?
Yeah, I would say one of the most frustrating things about the increase in tension is the increase in misinformation that's out there. And specifically, the increase in grifters who are talking a lot about menopausal symptoms and, listening to women about their perimenopausal symptoms and whatnot and hormones. But they're also selling all these things to help women. And, women, we're not used to paying a pink tax. Our t-shirts are more expensive. We need things for period protection. All of that is super expensive, way more than it needs to be. Birth control pills. Like if a guy had to take, I'm old enough, that I remember that it was like a $60 copay to get my birth control, when I was 20 years old. So, a lot of that stuff is very expensive for us. And even though that some is getting better, it's not, as good as it should be. And so that's really frustrating and then especially when, you're talking about some of the real influencers or like med influencers on Instagram will charge in excess of $1,500 for an appointment. What? Like, what specialist is charging that? And yeah, I understand you're really into this and this is the only thing you do, but why are you taking advantage of people? Why would a woman have to spend $1,500 for an appointment? So, and then on the other side too, there's a lot of myths out there about, pellets are the best way to give yourself hormones, or you have to have compounded estrogen and progesterone and testosterone to really individualize your treatment, and all the lab testing. Even serum lab testing is most frequently not needed, but there's the cortisol testing, the saliva testing, the urinary testing. All of these things cost hundreds of dollars, and it's not unusual for me to, by the time people have come to see me, and then you add on all the menopause supplements, but people would have spent thousands and thousands of dollars by the time I see them. And it's really frustrating because it just, like I said, I think infertility is another area of medicine that can happen where, people are trying to do everything to be as healthy as they can. And I feel like this has been echoed in perimenopausal women trying to do everything to be as healthy as they can. And then they have all these people pushing all these products and, supposedly the best, treatment option, which honestly, all the professional societies, 100% are all on board with FDA approved therapies. They're all bioidentical. People will try to say that you have to have compounded hormones or pellets to have bioidentical. That is untrue. We have FDA approved bioidentical hormones that are safe. And even without insurance, most of the time with GoodRx, I can prescribe hormones for people for 90 days worth will be about, $50 to $70. Like there's some little hacks we can make, and Mark Cuban, Cost Plus Drugs, they sometimes have really good prices. So we can oftentimes find ways to get them even less expensive. People don't have the insurance coverage, which we're seeing more and more of too.
Thank you for that. And then is there, it seems like there's some misinformation out there about the duration that women can stay on hormone replacement therapy for. And I was hoping you could speak to that a little bit.
Yeah, and I would just kind of glump into that, the dosing as well. Again, we have these FDA-approved products that have very consistent standard dosing, and that's all I do. And there's one caveat. Progesterone, the FDA-approved progesterone which is bioidentical, is suspended in peanut oil. So for people with anaphylactic peanut allergy, not like, I eat peanuts and it makes my stomach upset, anaphylactic peanut allergies, I have sent them to a compounded pharmacy for that. But otherwise, there's literal. Yeah, it doesn't really come up all that much. Actually, I just was thinking of this too, because a pharmacist talked to my patient and she actually brought up a peanut allergy, but he was really good. He sussed it out with her and was like, well, it just causes your upset stomach. It's not going to be like a true drug allergy where we're worried that you're going to, die. So that they're very safe at these accepted, studied dosages that we have with the FDA approved products. What is not safe is using, and there is a British, again, med influencer, OBGYN in England who got her certification taken away because she was using 3 of the highest dose patches. Well, highest dose implies that that's the highest dose you're supposed to use. And to use 3 of them, we can't say that that's safe. And we can't say that over the long term, because people who are oftentimes advocating for high doses of hormones are also advocating for using them the rest of your life. Like, you are going to fall apart if you don't continue to use these. And like all other medications, there's a time and a place for everything. there's about 15% of women who literally don't seek any assistance during menopause. They get a little hot, they take their overshirt off, they get a little cold, they put it back on. And, those women do not need hormones. There's no evidence to say that they're going to be any worse off than the rest of us if they don't use it. And then there's like 15% on the other side who are very symptomatic. At any time they ever try to come off the hormones, they will have their symptoms return, whether that's anxiety, depression, insomnia, low energy, hot flashes. Even I have patients that are 80 years old and I still prescribe them their estrogen for hot flashes because every time they try to come off, it comes back really bad. So, for most women, the timing is going to be about 5 years. And then even that, I would say 10 years ago, I would actually counsel women to take a break at 5 years just to see if they still needed it. That goal has been pushed back a little bit to about age 60. And what changes at age 60 is that our risk for breast cancer, just from aging, breast cancer risk goes up. And then you add estrogen and progesterone use on top of that, and that's an extra increased risk of breast cancer. So for those women who need both estrogen and progesterone, women with a uterus, that really at around 60 is what I counsel women now. Try to take some time off and see if you still need it. Your body will definitely tell you. Sometimes for hot flashes, it's within 2 weeks. Sometimes the hot flashes come back really bad. Mental, emotional symptoms, sometimes that's more in the range of maybe 4 to 6, 3 weeks or 3 months, people will start having those symptoms come back. The other thing I just wanted to I was just going to say really quick, I just wanted to say that there are a couple things that we actually do have pretty good experience. For some people, they might want to be using the hormones around the time of the final menstrual period for prevention or decreasing risk. I'm not even going to say like primary prevention. I'm just going to say in some people, you might benefit from a decreased risk of cardiovascular disease with estrogen when you use it around the time of perimenopause. Maybe for Alzheimer's and age-related cognitive decline. But believe it or not, that's around our age. The studies actually show if you're using estrogen later in life, like around the 70s or 80s, you might have an increased risk of Alzheimer's and dementia. So, by the time I would say, I'll say my cohort, I'm 55. By the time I get to be 60, we're going to have so much more information. So I oftentimes tell patients, it's like they don't have to worry about it right now. But by the time you're 60, it really is a good time to check back in and, kind of evaluate, do you still need this? What does the most current research say? And is there anything we can do to modify? Because the lowest dose that you need is what you should take. You're not going to take 10 ibuprofen if 2 are going to do the trick, right? So that's a great time to kind of refocus that.
Yeah, and I think it's so interesting because while, many of us are looking in the mirror and thinking like, oh my God, my face, and do I want to do some aesthetic work to make my outsides match my insides, etc. There's, I don't know, like the hormone piece, people sometimes are like resistant to or aren't educated on, and that's really inside out health. So it's interesting that we're so focused on the external, but without doing the things we can do, internally.
Right. I mean, that is so important. And that's the other myth I hate. And there's so many, again, even people who are certified menopause providers in their marketing, they really push the anti-aging aspect. And that is not this. Like, you are not going to not age if you have estrogen and progesterone, or even testosterone. That's just not what this is. It actually, the research too for systemic estrogen in terms of decreasing wrinkles on your face, that is just not there. Like, yes, Retin-A has been shown to do that. Hydroquinone for the dark spots. There are things, but it's not systemic hormones that are going to, like, minoxidil if you're losing your hair. But, estrogen is not going to make you have like a ton of hair or something like that when you're 60 years old. It's just not.
Yeah, and you mentioned the testosterone, and I think that's really interesting because I think there's a lot of misinformation about that. And then the other thing that whether I'll see, clinically with patients or just in talking to friends is I'm like, what is happening? Because the women are either prescribed like just crazy amounts, by their medical professional, which is like shocking to me, or just not offered at all. It seems like there's such a
With
wide
testosterone?
Yeah. So I was wondering like what your approach is in terms of when you do use the testosterone. Are you basing that off of symptoms? Are you going off of that free testosterone level? Like what's the move? What's the right move?
Well, it depends. And two resources that I'd like to share with, maybe you could put it in your notes or something for the podcast. But of course, the Menopause Society has a lot of really good information, especially for guidelines. Now, not 100% of people are going to fit into guidelines, but at least if you're working from that basis, then, you'll be able to find a provider too, because we have a provider search on there that can help support you through this. The other organization, it's very long, it's International Society for the Study of Women's Sexual Health, ISWISH. They have a great that's a provider site that can really educate providers on sexual health issues for women of all ages, but especially around the menopausal transition. They have a great patient site called Prolea. It's PROLEA. And that site has just so much information because there's so much misinformation about how much sex everyone should be having. And should you have a libido at this age? If you just look at your partner and they're like, I'd rather like mow the lawn, do the dishes, fold the laundry, or anything rather than do anything with you. Sometimes that can be from low estrogen or low testosterone. I will say, like a lot of the things that we talk about in perimenopause, sometimes it's important what has happened earlier in your life. If you've always been really depressed and you're still depressed in perimenopause, you might also have, and you certainly know this, a major depressive disorder or generalized anxiety that is, contributing to all the symptoms. They might get a little bit worse or they might get a little bit different in perimenopause, but you still have that issue from earlier in your life. And the same thing, if you've been someone who never had a libido, which are those people, or you've never been able to have an orgasm, that's not going to get better at this point at all. But it's also might not be due to low testosterone. So that, even if there's always a caveat, right, in medicine, I never say never always, but I say never test hormones except testosterone. And the reason for that is because our reference range for women, the safe amount of testosterone you should have in your body is pretty narrow. And it's just not as forgiving with dosing like estrogen and progesterone are. Our reference ranges throughout our life can be quite large. And again, we already know and have those products that are going to keep us in a normal range that the FDA has already studied. With testosterone, there was a consensus statement that came out from a consortium of an international consortium of endocrinologists and reproductive endocrinologists that suggested that women can benefit from testosterone replacement for low libido. But you have, it really is in the guidelines to check the testosterone first to prove that it's either low or undetectable, which a lot of women are, even as early as the late 30s. I find women that are undetectable testosterone. Or two, it's low enough that if we do a trial on the testosterone, we're not going to put that woman into a super physiologic level. And you're exactly right. I see women all the time. And just for, reference, I use SonoraQuest a lot. Their total testosterone goes from like less than 12, undetectable, up to 82. I saw a woman earlier this month who had a testosterone of 1900.
Whoa.
Even the male testosterone, the high is 1300.
And she wasn't interested in transitioning, I assume.
No. And you're exactly right. And you know what, there gets sometimes in these even these menopause conferences, because you will get people who do pellets, which is, in my mind, the biggest risk is that they always put estrogen, testosterone, whatever is in the pellet, into a super physiologic level. And people will always argue, well, why can't we have this much testosterone if female to male transgender are able to have that? And it's like, well, it's really, do you need that much? Like most women in my practice, again, with that reference range, they do really well right around 30 or 40. We're just getting them back into the normal range. They're nowhere that high. And most of the time, women are going to have side effects when they're in the super physiologic level. Look at gals with polycystic ovarian syndrome. They oftentimes walk around with a ton of androgens and they don't feel good. They're growing hair on their face, or on their chest. They have acne. Their hair is falling out. And we know that PCOS, a lot of times with that increase in androgens, can contribute to anxiety and depression as well, like really exacerbate those symptoms. So it doesn't feel good. And I know that, again, you're going to meet people out there who's like, I have to have my pellet because that's the only way I feel good. But I just try to encourage, again, I try to make it very clear on my website. I don't get those people typically because I'm basically like, I'm not going to give you a pellet. But most of the people that I see who've used pellets, and even if they're just coming to me for a financial reason, meaning that these other FDA approved products are, more cost effective for people, that they are like, oh yeah, I feel better. Like sometimes they'll gain weight with testosterone that high. So it's just, a transitioning female or a trans male might not care about some of those symptoms. They might be looking for those symptoms like increased hair growth, deepening of the voice and whatnot. So, I think that is part of it. The other thing is when your testosterone is that high, there is a portion of it that will get converted to estrogen. And there have been studies to show that increase in estrogen at that point can contribute to breast cancer risk and also liver function problems and bleeding. So if you still have a uterus, I've had patients that have started having regular cycles again when their testosterone level was too high and they weren't even using estrogen. So it really just isn't safe. And I honestly, in my opinion, I think it should be like malpractice to have someone with levels that high and continue to prescribe it over and over.
Yeah, I've appreciated your conservative approach of just helping, in my never be so humble opinion, myself just feel better, just simply feel better, because we shouldn't have to walk around in menopause symptoms or be symptomatic and just not be our best selves. It's just not necessary.
And then, I do think obviously like everybody is an individual, like you said, and certainly if you have, a genetic predisposition for certain types of cancer, et cetera, like you're going to want to work with your provider in a cautious kind of way. But it's so refreshing just to have like a very like straightforward, evidence-based, provider just like sharing the facts with us and our community. And I hope, I know we're like running down on time. I'm thinking, if you're willing, I would love to have you back on to specifically talk about mood symptoms as it relates to, puberty, oral contraceptives, menopause, and what we can offer people, and PMDD, I think it's so important.
I would love that too, because I believe that that's kind of like the fun part of medicine too, is because I get to work with so many other providers. It really does require a team approach. I'm referring to psychiatrists, I'm referring to therapists, and sometimes groups for patients that are struggling with that, because really, hormones alone are likely not going to do everything that patient needs them to do. And while again, so many people just say hormones, are going to fix all your problems, they're not. You may feel better, but yes, you are still aging, and other things will happen. You have the genetics you have the risk factors for mental health that you have, and that's why it's a team approach that oftentimes work best with the mental health issues.
Absolutely. And I also want to highlight, because this was a little nugget that you actually shared with Heather, who then shared it with me, and now I've been dispersing it. And I heard you mention it in terms of, hey, like we don't necessarily need to check hormone levels, but you did say when we do want to check hormone levels is when you're in your 20s, right? Like, or when you're feeling well.
Yes.
And that is something I think most people don't know.
Yeah. So there will, and that's what, of course, like people I think get frustrated with, because you really can't say never. And that it's more the unusual presentation we would want to be checking labs and confirming that there isn't something else going on. Like you mentioned, thyroid. I'm always checking thyroid levels because that too can cause women to, have few cycles if it's hypothyroid, or maybe stop having their period if they have untreated hypothyroidism. So that's exactly right. And then, another caveat to that is I have people who use the patch and they're still having hot flashes. We increase the dose. They still have hot flashes. And so at a certain point, when we get to that highest dose patch, sometimes I like to check the level to see if they're absorbing it. And I've had probably 5 patients who were not absorbing from the patch, right? So again, in that, very specific, pretty unusual situation, I'll check an estrogen level.
Well, I kind of want to end on one little comment that and get some feedback from you. If menopause is our, what do we want to call it? A second spring, second half of life, full of vitality. What's the invitation to women in this season, in your never to be so humble opinion?
Well, again, and I know this isn't the life or the path we all choose. I personally did not have children. But a lot of us can spend the 20s and 30s and 40s wrapped up in education, family, and work. And sometimes it does give us this chance to take a step back and really, I think that's what I said at the beginning. It's just good to take a step back and think, what do I want this second half of my life to look like? Because at our ages now, like women who are going into their 50s, they're expected to live into their mid 90s. And of course, the bell-shaped curve, we're all probably not going to make that, but a lot of us are. And 100 years ago, the age of menopause was around 49 to 50, not very different than it is now. But the life expectancy was like under 60. So we are just living a lot longer. And so it does really, I think, instead of saying, oh, I'm menopausal, my life is going to be over in 10 years, we have to be thinking like I might be blessed with having another 45 years on this earth. And what can I do to make those be as healthy as possible?
Yeah, love it.
Amen to that.
Intentionality.
I love it.
Well, thank you. And we will link your practice information with the show.
Yeah, I'm always happy if people contact me to just answer quick questions. I oftentimes do too, just from like referrals from patients for their friends out of state. I can help people find a provider that is doing more just like following the guidelines. Because even like I said, some of the Menopause Society people, they're doing pellets, even though the Menopause Society specifically, discourages their use. So I do try to help people find someone local for them too.
Awesome.
Good.
Well, thank you so much.
Thanks again for taking time out of your day.
Me.